It's time for another warm-up review. Let's get going. Which cell types are rich in smooth endoplasmic reticulum? The main ones you should know for step 1 are going to be hepatocytes, and then steroid hormone-producing cells of the adrenal cortex. Next, what is the treatment for heparin overdose? So for heparin overdose, you give protamine sulfate. Next, what is the treatment for warfarin overdose? So for a warfarin overdose, you can give fresh frozen plasma, and then you can also give vitamin K. All right, that's it for the warm-up. Let's get to that lecture now.
We've just been talking about the embryology of the heart. So now we're going to talk about congenital heart defects, which is basically what happens when that complex embryology goes wrong. Generally speaking, we can divide congenital heart defects into right to left shunts and left to right shunts. Now, which one of these do you think is worse? Well, would you rather have deoxygenated venous blood from the right ventricle shunted over to the left side in the systemic circulation? Or would you rather have oxygenated blood shunting over to the right and then going back to the lungs? I hope it's obvious that left to right shunts are much less dangerous in the short term. Babies can survive a long time with a mild left to right shunt, and they may be asymptomatic until the child's several years old and starts having exercise intolerance or shortness of breath or episodes of cyanosis. So right to left shunts cause cyanosis early, immediately after birth, but left to right shunts cause cyanosis much later on. Left to right shunts are less severe and also more common, which is fairly fortunate. There are three main causes of a left to right shunt: ventricular septal defect, which is the most common, atrial septal defect, and a patent ductus arteriosus. A VSD, or ventricular septal defect, is where there's a defect in the interventricular septum. Now, this may be completely asymptomatic, but it will cause a harsh holosystolic murmur as the ventricles contract and blood rushes across that defect from the left ventricle to the right ventricle. We're going to talk about heart murmurs in another video. About 40% of VSDs close spontaneously within the first 6 months, but larger symptomatic VSDs may need surgical repair. An atrial septal defect, or ASD, is a defect in the interatrial septum. In the last video, we talked about some different ways an ASD could develop, but the most common way is that the foramen ovale and the ostium secundum overlap each other. That means that the foramen ovale just doesn't close the way it's supposed to. This is sometimes called a secundum ASD, or a patent foramen ovale, and that's the most common type of ASD. Now, following the purple arrow here, we can see that blood can flow from the higher pressure left atrium over to the lower pressure right atrium, creating those higher pressures in the right side of the heart. So this leads to a very loud S1 heart sound and wide fixed splitting of S2. There may be some hypertrophy of the right ventricle. And the least common cause of a congenital left to right shunt is a PDA, or a patent ductus arteriosus. Normally, the ductus arteriosus remains open during fetal life to let blood from the pulmonary trunk bypass the lungs and go into the aorta in the systemic circulation. But then, after delivery, the ductus arteriosus is supposed to close. So this usually occurs within the first 24 hours or so after birth, but it may take up to 2 weeks. So initially, it's fairly common to hear a continuous machine-like murmur at the left upper sternal border in a newborn while they're transitioning from fetal circulation to postnatal circulation. But that murmur should resolve within 24 hours usually. If that murmur persists, that means that the ductus arteriosus has remained patent, as we see here. And this causes a left to right shunt as blood moves from the high pressure aorta over to the low pressure pulmonary trunk. Now, we treat a PDA by giving indomethacin, which blocks prostaglandin synthesis, and that closes the PDA. Remember, prostaglandins help keep vessels open. So we give indomethacin to block prostaglandin synthesis, and that allows the PDA to close. But sometimes we want to keep the ductus open. So in certain congenital heart diseases where you have cyanosis, where there's a right to left shunt, like transposition of the great vessels, for instance, which we're going to talk about later. But in those cases, you need to keep that ductus arteriosus open to allow oxygenated blood to make it over to the systemic circulation. So if you want to keep the ductus patent, you can use prostaglandins like PGE. Now, I said that right to left shunts were severe and dangerous, which they are, but I don't want to give you the impression that left to right shunts are completely benign and harmless. In fact, severe, long-standing, uncorrected left to right shunts can lead to something called Eisenmenger syndrome. So I want you to think about this sequence of events for Eisenmenger syndrome. You start with some left to right shunt, like a big VSD, and you're shunting blood from the left side of the heart over to the pulmonary circulation. Well, this increases pressure in the pulmonary circulation, and that leads to pulmonary hypertension. And then since the right ventricle has to work harder to pump blood against all that high pulmonary artery pressure, you're going to start to get some thickening of the right ventricle, and you're going to get some right ventricular hypertrophy. And eventually, that right-sided pressure can exceed the pressures over on the left side of the heart, and that left to right shunt that you started with will reverse flow, and it'll convert to a right to left shunt. So now you have deoxygenated blood going from the right side of the heart over to the left side of the heart and into the systemic circulation. And this leads to cyanosis, and shortness of breath, and clubbing of the fingers. So again, one reason you might give indomethacin to close a PDA is to prevent Eisenmenger syndrome. So left to right shunts like PDA or VSD are not cyanotic lesions initially, but if they're severe and if they're left untreated, they may develop cyanosis later in life. So before we talk about the types of right to left shunt that lead to early cyanosis, let's talk about coarctation of the aorta, which is one more non-cyanotic condition, but it doesn't really cause a shunt. A coarctation or a coarct is a focal circumferential narrowing of a vessel, in this case, a narrowing of the aorta. In the aorta, this usually occurs near the ductus arteriosus. But the key clinical feature to remember is that this classically causes elevated blood pressure readings in the upper extremities and low blood pressure in the lower extremities. So if you think of the aorta like a big garden hose and you kink that hose, the pressure proximal to the kink is going to be very high up in the arms, and the pressure distal to the kink down the legs will be low. So again, the blood pressure will tend to be high in the arms and low in the legs with a coarctation of the aorta. You may also see notching of the ribs on a chest x-ray because the intercostal arteries become dilated and that carves out little notches or indentations along the inferior aspect of the ribs. Coarctation of the aorta can also be associated with aortic regurgitation, either from coexisting abnormal valves or because with increased afterload pressure on the aortic valve, the valves are eventually weakened and they get damaged and they begin to regurgitate, and that can lead to heart failure symptoms. So now let's talk about right to left shunts, where blood is being shunted from the right side of circulation over to the left side of circulation, basically bypassing the pulmonary circulation. So this means that deoxygenated blood is going into the systemic circulation. That means these patients develop cyanosis very early on in life. So you can remember these 5 different causes of cyanotic heart disease because they all start with the letter T. You can also use the numbers 1, 2, 3, 4, 5 to help you remember them. 1 is a persistent truncus arteriosus because it's one big vessel. Then 2 is transposition of the great vessels because there are 2 great vessels that have swapped positions. Then 3 is tricuspid atresia, 3 for the tri and tricuspid. And then 4 is tetralogy of Fallot because tetra is Greek for 4. And then 5 is total anomalous pulmonary venous return because that name, total anomalous pulmonary venous return, has 1, 2, 3, 4, 5 words in it. And also it's total, so it has to be the largest number. So let's look at each of these one at a time. The first one was a persistent truncus arteriosus, not ductus arteriosus, but persistent truncus arteriosus, which is failure of the truncus arteriosus to divide into the pulmonary trunk and the aorta. So remember, this is failure of those neural crest cells to cause the aorticopulmonary septum to form properly. This is usually associated with a VSD. So as you see here, deoxygenated blood from the right ventricle is mixing with the oxygenated blood from the left ventricle, going back out into the systemic circulation. So you get some cyanosis and respiratory distress and heart failure. The second one was transposition of the great vessels, which means the aorta and the pulmonary trunk switch positions. Again, this is related to failure of the normal aorticopulmonary septum to develop properly. So the left ventricle is pumping blood back into the lungs, and the right ventricle is pumping deoxygenated blood into the aorta and the systemic circulation. So you have complete separation of systemic and pulmonary circulations, 2 completely separate closed loops. Now, in order for this to be compatible with life, you have to have some type of shunt to allow oxygenated and deoxygenated blood to mix, such as an ASD or a VSD. Or you may have to artificially keep the ductus arteriosus from closing in order to buy some time until the patient can go to surgery. And again, how do we keep the ductus arteriosus patent? With prostaglandin E. Remember, prostaglandins keep vessels open. The third member of the 5 T's was tricuspid atresia. Remember, number 3 for tricuspid atresia. Now, tricuspid atresia is where the tricuspid valve doesn't develop, so there's no opening from the right atrium into the right ventricle. And with that, the right ventricle is often going to be underdeveloped and hypoplastic. And again, this is incompatible with life unless there's a shunt. And actually, you need 2 shunts. You need an ASD so the blood can get from the right atrium over to the left atrium. And you also need a VSD so blood can get from the left ventricle to the right ventricle and then out to the pulmonary vasculature. And while we're talking about the tricuspid valve, let's take a quick sidetrack and discuss another anomaly of the tricuspid valve called Ebstein's anomaly. Ebstein's anomaly is a constellation of findings in which the tricuspid leaflets are displaced inferiorly into the right ventricle, and there's hypoplasia of the right ventricle, and there's also some tricuspid regurgitation or stenosis. Now, 80% of these patients have a patent foraminal valley with a right to left shunt, and you have a dilated right atrium causing increased risk of SVT and Wolff-Parkinson-White syndrome. And on physical exam, there's a widely split S2 and tricuspid regurgitation. Now, Ebstein's anomaly is associated with maternal lithium use. So if a woman's taking lithium for bipolar disorder and she gets pregnant, her baby would be at an increased risk of being born with an Ebstein's anomaly. So going back to the 5 T's, the fourth cause of right to left shunt is tetralogy of Fallot. Now, this one is very high yield, probably 4 stars, maybe even 5 stars. Remember, tetra means 4, and with a tetralogy, you have 4 defects clustered together, and you need to know all 4 of these defects. So the first one is right ventricular outflow tract obstruction, usually in the form of pulmonic valve stenosis. So that's the most important determinant of how much blood is going to be shunted away from the right side of the circulation. Then the second defect is right ventricular hypertrophy. You can think of the right ventricle having to get thicker and become hypertrophied in order to push blood through that tight stenotic pulmonic valve. Then the third defect is a VSD, and the fourth defect is an overriding aorta, which means that the opening of the aorta sits right over the VSD. So make sure you know those different components of a tetralogy of Fallot. Now, a student sent in a mnemonic IHOP for these 4 defects. The I is for interventricular septal defect, which is a fancy name for a VSD. The H is for hypertrophy of the right ventricle. The O is for overriding aorta, and the P is for pulmonic stenosis. Now, depending on how severe the defects are, the right to left shunt may only occur intermittently in tetralogy of Fallot, depending on the pressure differentials. So these kids may spend most of their time shunting left to right, meaning they're acyanotic. But there may be times where that deoxygenated blood gets shunted from right to left. For example, when the child cries, when the child feeds, or during periods of increased activity. And when that right to left shunt occurs, the kids become cyanotic. Now, older kids will learn to squat down during those cyanotic spells because that's going to relieve symptoms, because squatting increases systemic vascular resistance and it forces their right to left cyanotic shunt to go back to being a left to right shunt. They're physically forcing blood back across the VSD to the lungs to oxygenate it. So, if you have an infant with tetralogy of Fallot who's having these cyanotic spells, well, infants can't squat on their own, but you can artificially squat for them by pushing their knees up to their chest. That's going to increase afterload and relieve that cyanosis. Now, the classic X-ray finding with tetralogy of Fallot is that the heart looks vaguely boot-shaped on chest X-ray because of right ventricular hypertrophy. So, if they show you a boot-shaped heart in an infant, I want you to think about tetralogy of Fallot. But if they show you a boot-shaped heart in an adult, think about right ventricular hypertrophy from other causes like COPD or primary pulmonary hypertension. Then the fifth and final cause of cyanotic heart disease and right to left shunt is called total anomalous pulmonary venous return. This is where the pulmonary veins drain into the systemic venous circulation. So instead of oxygenated blood coming from the pulmonary veins to the left atrium, it might empty into the SVC or it might empty into the coronary sinus, but it eventually empties into the right atrium. So again, this is a completely closed loop, just like transposition of the great vessels was. And without some shunt, this is incompatible with life because there's no blood going into the left ventricle and the aorta. Let's also mention a few conditions that are associated with these types of congenital heart defects. Now, these have been known to turn up on practice tests, and you may see them on the real deal as well. Let's start with some conditions that affect the mother. We've already mentioned maternal lithium use, which can lead to which abnormality? Ebstein's anomaly, with that downward displacement of the tricuspid leaflets and right ventricle hypoplasia. Now, what about maternal alcohol use? Well, that'll increase the risk of several cardiac malformations, such as tetralogy of Fallot, VSDs and ASDs, and also patent ductus arteriosus. And then if the mother has pregestational diabetes, not gestational diabetes where she developed diabetes during pregnancy, we're talking about pregestational diabetes, diabetes that existed before she became pregnant, that tends to be associated with transposition of the great vessels. So those are conditions that mom has that affect the baby. But what about conditions the baby has that leads to heart defects? For example, congenital rubella infection increases the risk of a PDA, and it also increases the risk of pulmonary artery stenosis. DeGeorge syndrome, also known as the 22q11 deletion syndrome, can be associated with either tetralogy of Fallot or a truncus arteriosus. Turner syndrome is associated with coarctation of the aorta, as well as aortic valve defects like bicuspid aortic valve. And then trisomy 21 or Down syndrome increases the risk of an endocardial cushion defect. Remember, the endocardial cushion is the place where the ventricles and the atrium meet, right in the center of the heart. So endocardial cushion defects can lead to ASDs and VSDs. And that's it for the congenital heart diseases. So go ahead and work through the end of session quiz, and then we'll go over the answers together. All right, first question. What are the four components of the tetralogy of Fallot? Well, remember the mnemonic IHOP: interventricular septal defect, or VSD, hypertrophy of the right ventricle, overriding aorta, and pulmonic stenosis. Next, explain how the great vessels are attached in a transposition of the great vessels. So in transposition of the great vessels, the pulmonary trunk originates from the left ventricle, and the aorta originates from the right ventricle. Next question. A 45-year-old man presents with a blood pressure of 160/90 in the right arm and 170/92 in the left arm. There are no palpable pulses in the feet or the ankles. So what problem does this patient most likely have? Well, hypertension in the arms and weak pulses in the feet should make you think of a coarctation of the aorta. And the last question, what heart defect is associated with each of the following disorders? So that chromosome 22q11 deletion is associated with truncus arteriosus and also tetralogy of Fallot. Down syndrome or trisomy 21 is associated with endocardial cushion defects like ASD or VSD. Congenital rubella is either PDA or pulmonary artery stenosis. And Turner syndrome is coarctation of the aorta, and also remember bicuspid aortic valves. Think of aortic problems with Turner syndrome. So that's the end of session quiz, but let's also run through these rapid fire facts. If you hear a continuous machinery-like heart murmur, I want you to think PDA. If you see a boot-shaped heart on chest x-ray, think about tetralogy of Fallot or possibly other causes of right ventricular hypertrophy in an adult. If you see rib notching, think coarctation of the aorta. The next one, the most common congenital cardiac anomaly is a VSD. Definitely know that. And the most common congenital cause of early cyanosis is tetralogy of Fallot. All right, that's it for the congenital heart defects. I'll see you soon.
I think atrioseptal defect is one.
Yeah, that sounds right.
Dr. T!
I pity the fool who doesn't know the cyanotic congenital heart diseases.
But Dr. T, this is so difficult. However are we to remember?
Stop all of that jibber jabber. It's easy. It's the 5 T's. Truncus arteriosus, transposition of the great vessels, tricuspid atresia, tetralogy of Fallot, total anomalous pulmonary venous return. It's the 5 T's.
Wow, I get it now. Thanks, Dr. T.
No problem, shrimp. Now get back to studying.